Good morning.
I see you, Scott. Marlon, good morning.
Good morning.
All
It's
right.
actually good afternoon here and must
Oh,
be
yeah.
good morning there.
Good afternoon and good evening to some of you. I'm coming to you from beautiful Southwest Florida. You can see behind me. We'll give people a few minutes to settle in, and then we'll get started.
Yes.
Scott, is my volume, do I have a lot of background noise or is it okay?
It's perfect, actually.
Okay, good.
It's clear.
I'm right behind a fountain.
No, it's super clear. When are you coming back home?
Tonight.
Okay. I can't tell whether Paco's going to make it or not. I just can't figure it out.
He said he was arriving at 1 in Spain, in Barcelona.
All right,
so
that'd be fine.
He should make it.
He'll be doing
I thought his flight was delayed. That's why he might not make it.
Oh.
Hi, Kevin.
Morning, Marlon. Or afternoon, whatever it is. It's morning here.
Yeah.
It's, yeah.
I think that he already was on the program.
I see. What view do you have on? Which view are you using? How do you view more than one print?
I have side-by-side gallery.
Under view options?
It's on the top, top right corner.
Oh, I got it. Side-by-side gallery. That's it. That's what I wanted. Thank you.
Mm-hmm. Right. Okay, so maybe we should get started, Scott. What do you think?
Yep, I think so.
Okay. We have the pleasure of having Marlon Shah today, who's going to talk to us about radial neck fractures, I believe. Yes. All right. Marlon, please take it away.
Right. So try and share my screen.
Perfect.
So hope my screen is visible and my sound is audible.
Both, yes.
Perfect. Thank you. So first of all, those who don't know me, I'm from Ahmedabad, India. And Ahmedabad is the capital city of the most western province of India, that's Gujarat. A bit north to Mumbai, a bit southwest to Delhi. And more so it's popular because the birthplace of the father of the nation, Mahatma Gandhi ji. And those who visit India, they don't fail to visit Asiatic Lions in Gujarat. And for the last couple of decades, Prime Minister Narendra Modi had made this place very popular, and it's his birthplace and his constituency. Kevin has visited Ahmedabad for a few times, and he and his team from Cincinnati has been conducting mission trips in the charitable foundation where I also work. And it seems that Kevin enjoys his mission trip with, and we all are very happy with the services they are offering. Thanks, Kevin. And way back, he could also visit our comprehensive brachial plexus clinic, which we have been running for last now 15 years. And we have good exchange of thoughts. This year, I'm organizing POSICON, that's annual Pediatric Orthopedic Society India's meeting, and our next guest is Dan. Dan, thanks for accepting our invitation. And we are looking forward to have you with us. And those who all, I invite you all to attend this meeting.
Thank you.
I'm thankful to this guy, Federico Genovese. Federico and me were co-fellows at Sick Kids, and he introduced me to Francisco. And I hope this relation goes on for exchange of knowledge for many, many years from now. So thanks, Federico and Francisco. Coming to the topic, now if I present this X-ray of a 7-year-old girl with completely toppled off radial neck fracture, and or something like this where the radial head is completely off on the front, and if I propose these options, I'm sure that most of you would consider doing intrafocal pinning because a very severely displaced radial neck fracture, or some of you might do an intrafocal assisted pinning and followed by an antegrade tense nail to perform a Matizou technique. And we take open reduction as the last resort because there is huge association of complications. But very few of us would think that this fracture pattern is amenable for close reduction. And you are right, because the literature suggests when there's Judate 1 and 3, when the angulation is less than 30 degrees, this can be conserved because this fracture has remodeling potential. But when it is type 3, that is moderate angulation between 30 and 60 degrees, close reduction methods comes in play. But when there is severe displacement like Judate type 4, either percutaneous assisted reduction or open reduction has been advocated. There are different reduction maneuvers described in literature, right from Peterson maneuvers to Israeli technique to Nahartosh and so on. But all these methods were successful in treating Judate type 2 and type 3, but none of them uniformly achieved complete reduction in severely displaced radial neck fractures, that is type 4 A and B. And so what is OrthoKit's technique? Actually, this is the conglomeration or modification of the maneuvers previously been described for most severely displaced radial neck fracture. And if you apply this maneuver in a particular chronology, you can reduce the severely displaced radial neck fractures, type 4s, without any instrumentation. And that's what OrthoKit's technique is. So I'm going to explain to you this. Let us see this technique at a glance through this animation. The first step is to see the radial head in profile. And to see this, you have to maneuver or rotate the forearm under image intensifier. And you should be able to see the radial head as a rectangular piece. And this is the position where it's a pre-injury position of the forearm. And then varus force is applied by assistants and a longitudinal traction by surgeon, which decompresses the lateral recess. And with a thumb pressure, the radial head is pushed, which turns a type 4 to type 3 Judate. And then you should perform a simultaneous flexion pronation maneuver, which reduces this radial neck completely over the metaphysis. And one can check the stability of this reduction in flexion and extension in both the planes. And if it remains stable, then you can just apply a plaster in mid-prone position and you can avoid any instrumentation. If we see the biomechanical basis of this technique, when we flex the elbow, it obliterates or tightens the posterior capsule. And when you pronate and flex simultaneously, the annular ligament, accessory collateral ligament, and lateral radial and ulnar collateral ligaments become tight. And this tightened ligaments places the radial head in its position. And we have seen that when we supinate this reduced radial head, it gets translated. And so that pronation maneuver is extremely important. So if this technique is performed in this chronology, we could reduce all the type 4 radial neck fractures without any instrumentation. Let me demonstrate you this technique in a real time in a 6-year-old girl with type 3 radial neck fracture. And we need to position the child on the radiolucent table. As you can see here, the child lies on the edge and the forearm should be on the radiolucent table. An image intensifier comes from one side. And one should first try to see the forearm under image intensifier so that they can visualize the radial head as a rectangular piece. This is the radial head in profile. and you should perform all the further maneuvers in this position of the forearm, where the radial head looks like a rectangular piece, as you can see in the index image intensifier image in a moment. So this is the position you should remember when you perform your further maneuvers. The third step is to give longitudinal traction, which surgeon gives, and a counter traction is given by the assistant from the top. And then your assistant should give varus force. This combined longitudinal traction and varus force decompresses the lateral recess and makes place for the radial head to pass between the capitellum and the metaphysis. So you can see this. And once you do this, you locate the radial head with your thumb on image intensifier. In some chubby children where it is difficult to locate, we see the lateral view of elbow to make sure that your thumb lies on the radial head. And then you push this radial head, which will convert a type 4 Jude to type 3. And once it is partly reduced, one should do the flexion and pronation maneuver, which is done simultaneously. And then you will see the radial head is reduced anatomically. And once it is reduced, you check the stability of reduction in both flexion and extension in AP and the lateral plane. And for that, you should turn the extremity externally, as we do in stable supracondylar fractures, and range the elbow through the flexion extension and make sure that the radial head is not moving. And once this reduction is stable, you can apply plaster in mid-prone position. So if we see the radiologic correlation, this is the X-ray of child which I shown before. After longitudinal traction and varus force and thumb pressure, we could convert it from type 4 to type 3. And with the flexion pronation maneuver, we could reduce it completely anatomically, and it was stable throughout, and we avoided any interfocal pin or metazu tense nail. And this is a year follow-up. As you can see, it's completely reduced and child gained full range of motion. Let me show you another example. This is again a 10-year-old boy with completely toppled off radial neck type 4B. Again, we could reduce it with the same technique, and we did not require any instrumentation. Now, this third example is a daughter of my orthopedic colleague, and she had very severe injury where the radial head was lying in the front, as you can see. And we could employ the same technique, and we locate the radial head well, and this is how we could reduce it. We see sometimes radial neck fractures in very young children where radial head is not ossified. One can do an arthrogram and should be followed by the same technique, and you can reduce it very well, as in this case. Where this technique may not work, what we have seen is when the injury is more than 7 days old, the radial neck gets a bit stuck. Although in a couple of instances, I have used a blunt K-wire to do an osteoclysis, and I could successfully reduce them back. But in my experience, when injury is older than 7 days, many a time we may fail. And the one where the radial neck fracture is associated with elbow dislocation or a Jeffrey type of elbow dislocations, their ligamentotexis has been disrupted, and there this close reduction technique may not work, and you may have to adhere to other modalities of fixation. However, I receive examples from my colleagues and my ex-fellows. For instance, this bilateral radial neck fracture child, who especially on the left side had a complete dislocation with avulsion of collateral ligaments and completely topple of radial neck. He could reduce it with this technique after elbow reduction. And he found radial elbow pretty stable after this technique, and he conserved it. This is 3 months follow-up of this injury. And surprisingly, this girl had full range of motion at 1 year follow-up in both flexion, extension, and pronosupination. However, I do not recommend, I suggest that you might need to fix the radial head, and close reduction may not work completely in dislocated cases. This technique has been published in Indian Journal of Orthopedics in 2020. And those who want to look at it in greater details, subsequently we could publish it in JBJ's Essential Surgical Techniques in 2022. So take-home message is isolated, severely displaced radial neck fractures, that is Jude type 4, without any associated elbow dislocation, can be treated by OrthoKit's technique without any instrumentation. And unstable or neglected cases should be reduced and they might need instrumentation. So thank you very much for your patient listening.
Wow, Paul, that is fantastic. What an eye-opening presentation, actually, for those of us who treat radial neck fractures. And I will tell you that I've not had the same success in reduction, and I'm anxious to try your technique. There's a couple questions that have come up, and I think the main one for me as well, and Scott suggested this, is do you use an arthrogram when you're doing your reductions? I find that usually is helpful, especially when you have that upside down radial head fracture that it's very difficult to visualize, particularly in younger kids.
Yeah, so you do the arthrogram through a conventional posterior approach and try to move the forearm under image intensifier till you see a rectangular piece of radial head. And that's the position in which you will do all the further maneuvers. The problem is many a times people try this technique and they do not visualize the radial head in its profile and they start reducing. When you kind of pronate the forearm more than it should be, then it already obliterates the space between joint, the capitulum and the metaphysis. And the moment you bring it in pure profile, the radial head moves in like a disc. We push in the computer. So it's very important to see the radial head in profile. It becomes difficult when the radial head is not very ossified. So you need to have a very good arthrogram. But it is fairly straightforward when you see in older children where radial head is ossified.
Does it matter if the head is anterior more, lateral more? Because you're basically positioning it wherever it may be to get that rectangular profile.
Yeah.
Does that affect the reduction?
I would say now we have done about 50 cases collectively with my friends, and about 90% times this is anterolateral. So more anterolateral. The one which I show you, my friend's daughter, she was pure anterior. So there you have to spare some time to locate the radial head even in lateral plane on your image intensifier and properly position your thumb over it. And there you try to push the radial head still when you are in extension. And once it is placed, then you do the pronation and flexion maneuver. But in most of the times, it is more lateral than anterior.
And the video you showed, basically you need 3 people. Is that correct? Or do you think you can get away with 2?
Oh yeah, you need 3 people because the surgeon would give longitudinal traction with the right hand and the thumb pressure. The surgeon will use disc. The nurse will give counter traction and an assistant will give varus force. So 3 people are required, yeah. And the person who's showing image intensifier, so IIT technician is one more.
So another question for me is we've seen the standard sort of party line, right? The recommendations in the literature, 30 degrees is fine, right? We've not seen that to be the case. We see Scott, stop me if I'm over speaking. But we have seen these subtle malunions of like 30 degrees or even slight translations of 5 millimeters. And they get this sort of cam effect of the radial head and it pops out at certain, I feel like it's an intra-articular injury.
I agree.
And an anatomic reduction is really
It's
important.
mandatory.
Yeah.
So I agree with you, Dan. If you see, John Wedge published a paper way back in, I think, in 90s or 2000 from sick kids, and they have found that the translation of more than 2 millimeter leads to a cam kind of impingement, and the radius does not move fully in the radial notch of ulna, and those patients always had a problem of rotation restriction. The Jude says that it's angulation, but if it is angulation of 30 degrees with more than 2 millimeter translation, that patients may have restriction of forearm rotation terminally, and so we should try to reduce it as anatomically as possible. That's what I prefer,
Yeah, it's interesting because it is such a complex joint. It's not just a radiocapitellar joint, it's also a radial ulnar joint.
Yeah.
And so you need to interact with both surfaces in a way that, and keep in mind that the radius will spin and then flex extend, right? Or otherwise flex extend and spin, right? So there's
another observation then I have seen is some colleagues, they have just applied plaster in supination in angulation of about 30 degrees. And when they bring the children in follow-up, they have found more angulation and translation. So my advice to all the fellow colleagues is, in supination, the ligaments are lax and it will give more space for radial head to move. So even though you don't attempt a close reduction, apply plaster in mid-prone position so that that radial head will not move. You understand what I mean? Because if you apply plaster in supination, you are making those ligaments lax, and that radial head may drift a bit or in follow-up. And so better you apply it in mid-prone, and they never lose movement. They gain full range of motion.
So the corollary to that is, if you have a elbow dislocation with a radial neck fracture, but you manage to get it reduced, are you more likely to pin those because of the lack of soft tissue stability?
Yeah. So I personally have not been successful to manage elbow dislocations with radial neck with this technique, but two of my colleagues and fellows, they sent me the follow-up pictures. One of them I included in my presentation, but they were a bit stable on what happens is you can reduce the radial neck, but the moment you extend, the elbow gets dislocated again. Right. So unless you stabilize the radial head well, either with a K-wire or a Matazu, I'm not fond of doing TENS, a retrograde TEN. I would put on K-wire from the extra articular cartilage. But I would say that you need to, fix the radial head when it is associated with dislocation.
Yeah, there's a couple more questions here in the chat. One of them is, how many times would you repeat the maneuver? So if it doesn't work the first time, would you do it again? And then how many times would you do it before you try something else? Yeah, so
I would suggest that you try 2 to 3 times at least. The reason behind is many times you will see the 2 times you do, you will see the radial head is almost reducing and not 100%, and you come back. And when you are novice to this technique, you should have faith in this technique, that this works. And the time it will work, you will get, you will be very happy that you could reduce a completely displaced radial neck fully. But you should try 2-3 times. Every time you will see you can put the radial head back more anatomically than before. And if you are not able to move the radial head, then confirm that you are giving proper pressure. You are not in anterior or posterior to the radial head, confirm it on lateral profile.
Scott, did you have something else?
Just a couple quick things. So I can see really struggling with one that's anterior, right? Because I think because your thumb's going to be in an awkward position, but you'll say sometimes on a anterior head, you'll use a lateral X-ray and then perform the same maneuver. Is that correct?
Yes. So
Yeah.
you look at the lateral and you put your thumb right on the radial head. And there, sometimes you need to rotate the image intensifier, then the arm, and then you will be successful.
And then, do you think your technique, just like the metazo, relies on some intact periosteum somewhere?
Yeah, come again, sorry?
Do you think your technique, also like the metazo, relies on some intact periosteum somewhere between the neck and the head?
More than periosteum, I think it's the ligamentous complex, because I have seen completely displaced radial head. So and we can see there is very thin periosteum would be intact laterally, but more so if it is not associated with dislocation, all the ligaments are intact, and with this maneuvers we are kind of maneuvering through the ligament, making them tight, which helps in keeping the head in position.
And then one more question is, I can see, especially in a difficult case, say on a third reduction, you finally get it, and it's, how do you follow it? Because you've lost your ability to do an orthogram. So how often do you follow them? Do you get, obviously, just AP or lateral X-rays? You take them out of the cast and get an X-ray? What do you do in follow-up?
So the patients are followed at 1 week, and we try to get AP and lateral X-rays. For getting a good AP X-ray, you have to maneuver the X-ray bin. And if the position is good at 1 week, we would follow them at 3 weeks. Children younger than 6-7 years, we keep plaster for 3 weeks. And older children, we keep it for 4 weeks, and then we remove it. I agree with you that the problem comes where the radial head is not ossified. But there, we just get clue about the whatever ossification center is there. We try to compare immediate post-op PULM, and it's not that easy when we compare with that radial head is ossified. So I agree with you then.
And then the very last thing, Dan, and I'll stop, is sometimes they don't give a history of a dislocation, right? You can just tell by the amount. You can tell by the amount of swelling, or you get some sense that they're really swollen. What about those cases? Do you leave the option open to do A and or B?
Yeah. So that's a great question, Scott. And I always teach my fellow that you don't just look at the X-ray, but look at the child. What I have seen in isolated radial neck fractures, they have pain and swelling only on the lateral joint line. But when it is associated with dislocation, they have a global swelling, and they have tenderness on the medial as well as the posterior side. So when they have global swelling and tenderness on medial and posterior, I would assume that this might be a dislocation which is spontaneously reduced, and this can create challenge in surgery. So we keep those options of fixation open in those patients.
And Dan and I, in those cases, have actually delayed surgery too. The ones that you're going to take right to the OR, if you take the dressing down and they're ginormous and there's ecchymosis medial and lateral.
Yes.
We'll wait 3 or 4 or 5 days later. It's just an easier operation.
Right. That's right. Agree.
But I will say that I'm going to echo what Dan said. We have not been successful, but maybe we've not been doing it right. And I think what we'll do.
I will share these videos and animation. We do not have faith. Being orthopedic surgeons, we have been trained that all severe needs instrumentation, but try to have faith in this and try a couple of times. The moment you get the reduction, you will become brand ambassador of this technique.
Yeah. Well, I think the PALMA and others from the way back when of closed reduction of fractures, and they'd be appreciative of this comment. We are definitely going to give it a go.
Mm-hmm. Yeah, and I think this is our first talk that I can recall on PULM about a closed reduction technique. So congratulations on that. Love it. We surgeons don't. It's not as sexy sometimes, but so important. right? So important. All right.
You know,
So
we know
we
one more
are
comment,
officially-
Dan, real quick. So, you know, when I used to take care of adults, it's super important that when they would dislocate their elbow and you get an X-ray, a lateral X-ray, and it almost looks like they're posterolateral unstable, meaning the radial head drops from the capitellum. And a lot of times the residents and fellows go, "Oh my gosh, the patient needs surgery." That's not the case. If you take that adult, put them in pronation, just like you're saying, they can tighten up that posterolateral corner just enough, and the radial head will migrate in an anterior direction, even in adults. So I think the concept of pronation for this type of injury is interesting. When you think about it, it's fascinating because Montage is the opposite, right? Montage is going to reduce better in supination. This is going to reduce better in pronation. Food for thought. Thank you. That was very informative.
Thank you very much.
And shockingly, we're on time, Scott.
Oh, we have plenty of time to mess that up. Kevin's up next, I think.
I see that. So next up is Kevin Little, who's going to talk to us about thoracic outlet syndrome. And Kevin does a shocking amount of thoracic outlet from Cincinnati. Kevin, take it away, please.
Good morning. You guys hear me okay?
Yep.
Cool. Well, I can easily get you guys off of time schedule if you want to talk about thoracic outlet syndrome. But thank you, Mullen, for your great talk. I really agree with you. The pronation maneuver, I think, will help, especially if you think about, how it works for nursemaid's elbow, and that, really helps pop that back into place. The hyperpronation works better than the supination flexion. So people who reduce nursemaid's elbow, I've only reduced one because I caused it, but that's a whole different story. But I will definitely try your technique and talk to you about it in Ahmedabad when I see you in January. So.
Yeah.
Cool.
That's right.
So I did not start off in my job at Children's Hospital thinking I would take care of thoracic outlet syndrome. I thought I'd left that behind in fellowship. And so it was sort of eye-opening to see, these patients start showing up more and more. And I think it has to do a lot with repetitive overuse and kids who are doing way too much sports in the same sport all the time. It used to be you had a football season and a basketball season, a baseball season. You do different things. You didn't do so much. But now everyone has to play the same sport year-round in order just to compete at the higher levels to try and play on the high school teams. So a good introduction is to meet one of my patients. This is Drew. I met him when he was a 16-year-old sophomore. He was already a starting quarterback for his high school team, being recruited by different colleges. He was in the preseason, doing a lot of stuff, having some shoulder pain, had some arm swelling, and then his whole arm started numb and tingling. And he went to see a few different people to try and figure out what's going on. Eventually, they got an ultrasound of his subclavian vein. And sent him to our Children's Hospital ER because his one arm was super swollen. You can see the right arm, he's right-handed. He's got some dilated veins in that hand. It's definitely a different color and swollen.
Hey, Kevin.
Kevin,
we're not seeing your slides. They're not
You're not seeing my
advancing.
slides?
We see your slides. We're just not in presentation mode, Kevin.
Yeah,
okay, I was. Let me see what happens here.
So you just make the slideshow run from the first slide.
Yeah, I did that, I thought, but let me try again. No problem.
We've lost your slot. Your
Share
sharing.
your screen.
Yeah, I turned off sharing for a second so I could.
Yep.
Oh, no.
Yay.
All right, so this is Drew. He likes to throw football. This was his arm. If you didn't see that before, you can see his right arm. He's right-handed. He has some significantly dilated veins on the back of his hand and a definitely different color to his hand after getting his diagnosis. He got an MRI. It shows a complete thrombosis of his subclavian vein. This is something called Paget-Schroeder syndrome. So it's an effort thrombosis. The more overhead motion you have, you're pinching your subclavian vein between your clavicle and your first rib. Eventually, that leads to basically intimal swelling and eventually thrombosis. So he had a thrombolysis performed with interventional radiology. They were able to break up the clot. They put him on an oral anticoagulant called rivaroxaban, and then he went home. We did his thoracic outlet decompression 10 days later. So that involved a supraclavicular incision, anterior scalenectomy, first rib excision, and sort of decompression of the space. And then we look at the vein at the same time, make sure it looks pretty good. And so he's now 4 years post-op. He's on Division I scholarship, playing quarterback and locally in a Division I setting. No pain, full strength, and the ubiquitous, nice quote that he wrote about us at Cincinnati Children's. But he, a lot of these kids don't know they're having problems. It just hurts, and there's whatever, that's how it is. And then you decompress the thoracic outlet, they're like, oh my God, this is what it's supposed to feel like. Like, they feel a lot better about it. So what's the thoracic outlet? I think of the thoracic outlet as a space, right? So the thorax means chest, outlet means exit. So the exit from your chest. So your vessels, subclavian artery and vein have to exit your chest and go over your rib and under your collarbone. They go between the scalene muscles, right? So anterior middle scalene, you have your brachial plexus and your subclavian artery, and then anterior to the anterior scalene is your subclavian vein. And because there's different structures in different places getting different compressions, you can have different symptoms. And that's, I think, why it's not really recognized, because there's no gold standard test and there's no way to really say, like, you have thoracic outlet syndrome or not, because there's different symptoms for different areas. And so people don't believe it exists in some cases, but it definitely is a real diagnosis. The more and more I saw this, the more I kind of figured this is a little bit like a Guillen's canal, where there's different zones and different compression. So the way I think about it is zone 1 or level 1 compression. Your subclavian vein is trapped between the anterior scalene, anterior first rib, and the clavicle. So it makes a very narrow triangle. And when you bring your arm up overhead, that really compresses that space, because the collarbone has to rotate, and that rotation of the collarbone can compress that space. So that's sort of the Paget-Schroeder syndrome type thing we'll talk about in a little bit. The second place of compression is the interscalene compression. So the place between the scalene muscles, it compresses the subclavian artery and brachial plexus. You can see that with cervical ribs, where there's tight bands. You can see the accessory scalene muscles or abnormal anterior scalene causes sort of a cat's eye type of compression. So the anterior middle scalene should be a triangle like this, but sometimes it's more of like an oval, where the brachial plexus and artery can be compressed significantly. And then the third point of compression, which is probably the most common area in kids, is this costoclavicular compression. So when your arm is elevated and externally rotated up high, for the kids who do overhead sports, swimmers, volleyball players, baseball pitchers, football quarterbacks, those patients, you are compressing all of the structures sort of laterally over the maximal apex of the ribs. The rib is sort of a C-shaped. Anterior is where the vein is, but when you have way out laterally between the rib and the collarbone, you get a lot of neurogenic type of pain in that space. It can also cause lots of blood flow. You can have arm turn white with overhead activities, but it's really more of a neurogenic type of thing. And the fourth level of compression or zone of compression is subcoracoid. So I think of the thoracic outlet as like a tunnel. The entrance to the tunnel is at the first rib, and the exit is underneath the coracoid. And that doesn't cause a lot of problems until you're overhead. So your coracoid acts like a hook, and when your arm is up, your plexus and vessels come down underneath the hook and then get tethered there as they go up the arm again when your arm is overhead. So that's sort of fourth point of compression, your pectoralis minor syndrome or subcoracoid compression. The thing to think about, TOS is a clinical diagnosis. Like, you can't use any test to do it. So you have to correlate history, activities, types of pain they're having, and then correlate with the exam findings. So we think of this as like pain in the shoulder, supraclavicular fossa, radiating down the arm, can have associated pain in the periscapular muscles. Look for numbness, tingling with overhead activities. So even stuff like washing your hair. Can you wash your hair without having to drop your arm and rest for a bit? Can you put dishes away in the cabinets above the dishwasher? And then look for things like engorged veins, swelling, arms that turn different colors with activities, or ADLs. And then what kind of sports are they in? Are they doing sports or music or something where they do a lot of overhead motion? And this has been all sorts of different sports, but the most common ones sort of seem to be swimming, volleyball, baseball. And it's much more of a female problem than a male problem. In our big series, it's probably 80% female. And overall, I think in the subclavian vein thrombosis patients, about 50-50. But in the typical neurogenic stuff, it's really like 80 to 90% females. And so it's a lot of the female sports like volleyball, softball, basketball, that sort of stuff. We're looking for different things that are eliciting compression of the thoracic outlet. So the Adson's test, where you have them look and move their neck side to side while you're checking their pulses, because that can stretch the scalenes and tighten them together, cause compression of the subclavian vessels. The Wright's test or hyperabduction test, I generally look at what angle that becomes positive, because if you are losing your pulse at 80 degrees of abduction, that's way different than 140 degrees of abduction. And everyone's space gets narrowed a little bit with abduction. Just how high does your arm get before the pulse is completely obliterated? And then we do the Ruse test, which is an effort test, where you sit there like this and have them talk to you for a minute while they're trying to move their hands to see how long they can last before their muscles kind of give up from the lack of blood flow. And then based on this, we can sort of evaluate what types of TOS they have. So, what we talked about with our first patient, Drew, had a Paget-Schroeder syndrome. So this subclavian compression, it leads to like arm turning blue, venous dilation, phlebitis in chronic cases. We had a lot of arm swelling and heaviness and pain with overhead activities. Arterial compression, you see it rarely, but you see kids who have arm turn white when they're overhead. When they're doing the Ruse test, you can see their fingers sort of blanch and turn white. And that's often with cervical ribs or other things that are really compressing the arteries. Nerve compression is more numbness, tingling, pain. And then you can think of like the nerves as, double crush. And I've seen triple crush and even quadruple crush, right? So if you have entrapment at the brachial plexus area in the thoracic outlet, you can have pain at the pectoralis minor, so they complain about shoulder pain or tightness right in the anterior. A lot of them have cubital tunnel type symptoms, and even some have had Galen's canal type symptoms. It's most commonly the ulnar nerve or the medial cord, because that runs right over the first rib, right next to the subclavian artery. And then your distal thoracic outlet syndrome or pectoralis minor syndrome, that's really like sort of your double crush type of thing. And we'll talk a little bit more about that. So I typically will confirm our diagnosis with advanced imaging, but it's not a gold standard test. It tells you how big the space is, and it tells you how much space they have available when they're doing overhead activities. And then if you look for patients with rib abnormalities, probably about 5 to 10% of our patients have rib abnormalities. So you can get a CT. This kid had actually a sort of a synchondrosis between the first and second rib. And that caused the second rib to be hypertrophic and the first rib to be narrow in the space. So if you look kind of from a fist, neck down, the space on the left here is more open. The space on the right just naturally. So there's a less space with this type of thing, and that causes problems. So our gold standard test is an MRI, MRA of the chest. So we have them with their arms down, arms up, looking at the subclavian vessels, looking for compression, looking for bands with the MRI. And then you can see the blood flow before and after. And you can see, I'll try and do this here. In this patient, especially with the arms up, you can see this is the artery. There's a point of compression here at the rib. There's even a point of compression kind of at the pec minor with the arms up. So another test, we see with the arms down, you can really see good blood flow through the subclavian veins, the bigger ones, and the subclavian arteries as they're coming here. With the arms up, oftentimes you can see compression, even mild on the left, but significant compression on the right side in this patient. I like to look at the sagittal view. I think that's the most helpful because you can see with the arms down and the arms up, there's a difference in the space available for the subclavian vessels and the brachial plexus. So in this patient with the arms down, there's a pretty big subclavian vessel. But the arms up, it gets narrowed. And it's really between the collarbone here, the rib, and then the anterior scalene. It forms a significant triangle or box for that vein to get compressed. And then the kids that have the thrombosis, you can see sort of normal flow on the right side and then abnormal flow on the left side here, showing significant thrombosis and collateral flow. You can see these extra veins coming through. So that's what we're looking for. Do they have collateral veins? Do they have compression? How much Is the subclavian vein artery obliterated? You can actually see complete obliteration or occlusion of the vessels with the arms up in that space. And especially on this one with the arms up, you can see the complete narrowing of the subclavian vein as it's supposed to go through the thoracic outlet. So heart treatment has evolved over time as we're seeing more and more of these patients. It's really, we start off with physical therapy. One stuff to really address the underlying problem. Can we stretch the scalene muscles? Can we do nerve gliding exercises through that space? We want them to modify the activity, so avoid the overhead stuff that causes pain, avoid some of their issues that they're having, especially if they're washing their hair. The ways to sort of counteract that and do stuff to help modify activities. Once that fails, we try more physical therapy, see if that works. So generally about 3 to 6 months of physical therapy, except the patients that have a thrombosis. Those kids, we've sort of exhausted their treatment, but we generally have to do their surgery at some point. We started working with our anesthesia pain team, and they're able to do scaling Botox injections and even pec minor Botox injections to see if that will open up the space. And that's helped in a lot of our patients. We did some injections of cortisone into the brachial plexus area to try and calm the nerves down, and that never works longer than a month or two. So we've given up on sort of cortisone shots for these, but really work only on Botox injections. The Botox will help relax those muscles. I think gives you some time to stretch, can open up that space a little bit and release some of the compression. Long term, we don't really know exactly if that's going to last long enough, but we've certainly postponed surgery in a bunch and had a few patients that have gotten a lot better. I think there is a tipping point in treatment where there's a point where too much compression and too much overhead use, and there's nothing you can do to really get it to stop hurting and stop being a problem, because you have to take care of yourself. You can't just stop living and taking care of yourself, brushing your teeth, washing your hair, that sort of stuff. But if you can sort of delay that tipping point or stretch it out a little bit with Botox, you might be able to get to it. So if all that fails, we do surgery, and we don't do the surgery as a first line of treatment in most patients, just because it's a big deal surgery, right? So we make an incision just like we do for brachial plexus explorations in the supraclavicular fossa along Langer's lines. We find the clavicle. We take the part of the sternocleidomastoid down because sometimes it's hypertrophic. Take the fat pad off, and we find this is the sort of the close-up view. This is the omohyoid muscle. You move it out of the way, and then you get down to the brachial plexus. So we find the anterior scalene. Here's the anterior scalene. Here's the phrenic nerve. Hopefully you guys can see the pointer that I'm using here, but see the phrenic nerve on the anterior scalene. So we want to free that up, make sure that's not in the way. And then we take out the anterior scalene completely. So we sort of, in my experience, it's best to sort of use a bipolar and very carefully cut through the anterior scalene at the level of the subclavian artery. And so that way you can follow the artery all the way through the scalene into the mediastinum, but very carefully peel it off that without disrupting it too much. And then that leaves sort of the distal half of the scalene attached to the rib, which you then can take out as you're taking the rib out. Then we use Kerrison rongeurs, and we slowly nibble out a section of the anterior and slowly nibble out a section of the posterior to the brachial plexus rib. That leaves a floating piece of rib that can be anywhere from like 2 centimeters to about 6 centimeters in space, depending how much space you have and how careful you are. And then we have to detach that from all of the intercostal muscles, which are really thick and really huge and tight fibrous strands. It's really hard to get that piece out from underneath the brachial plexus. Once you do that, you have a much bigger space. So in this picture here, you can see this is after taking out the rib. You have much more space here. Here's the subclavian vessels and brachial plexus. Once you take the anterior and posterior rib, this is the brachial plexus and subclavian artery here. It's a little bit hard to see, but it's much more open and decompressed than it was before. And once it's wide open, you can actually do a Valsalva maneuver and make sure you don't have any injury to the lung or to the pleura. Because the rib is attached to the pleura, we have a pleural tear about half the time we do this surgery. Very common to do that. Doesn't seem to cause any issues. We used to try and repair it, but that actually is worse. Just let it go. It'll heal just fine. It hurts a little bit more to take a deep breath. We have incentive spirometer going on. And then gets better on its own. If you have a lung injury, obviously you see some bleeding. We've had that happen. We'll talk a little about our complications, but that involves a test tube for 3 to 5 days while the lung heals, and then it gets better on its own. In this picture here, you can see like all these pieces we take out, we can reconstruct a rib a little bit on the back table and take a picture of it and show this is what we did to the family. So sometimes you can take a big old chunk of rib out too. We clean it up sometimes and make it look pretty for them. We haven't figured out a way to give it to patients. There's a quarterback for Notre Dame who had Paget-Schroeder syndrome in high school and has rib taken out and has like a rib piece on a necklace that he wears all the time to show off how cool he is. So now we've done probably 160. I'm not sure exactly. We probably do one to two a week sometimes, but like 30 to 40 a year is what we're up to. And our mean age is about 15, but we treat young adults sometimes, depending on if they have connection to children for whatever reason. Really don't want to take care of the older adult patients, not our expertise by any means, but young adults into the early 20s we take care of. It's mostly females, less males. We did, looking at the subtypes in adults, it's much more neurogenic. It's probably 80% neurogenic and 20% vasculogenic. In our experience, about 30% pure neurogenic, and 20 of vasculogenic, and Paget-Schroeder syndrome. So our sports involvement, you can see here, a lot of overhead sports. Swimming is one of the worst ones for that because they have to do a lot of deep breaths, and that deep breaths hypertrophies the scalene muscles when they come out of the pool or out of the water to take a deep breath. So some people have done overhead musical instruments as well. So recently published this, our results in the Journal of Hand Surgery, looking at our patients. Overall, our provocative testing is really, that's a good sign that we've caused improvement. The percentage positive has gone way down in all of these patients. And there's no one test that works the best. So you can see, Wright's test is probably most positive, but it's never 100%. Roos and Adson's tests are helpful too. So we really have to do all of those and see like what we think their diagnosis is. So it's a little bit of a bigger showing of our post-op. So overall, I think 8 out of 10 of our patients return to previous level activities. A lot of the 20% that did not return are swimmers who decide they don't want to wake up at 6 in the morning every day and swim twice a day sometimes. And so they're going back to other sports because they just don't want to be as dedicated to swimming anymore. Though we've had patients return to swimming, gotten college scholarships, gone to Olympic trials, so they can go back to full activities if they want to. Everybody's improved after surgery. I think it's because we have rigorous selection criteria, and we really try everything we can not to do surgery on these patients. No one's had worsening pain. Sometimes the neurogenic issues pop up a little bit after surgery. We've irritated nerves. We've caused some mild numbness, some mild weakness after surgery, but that's all gotten better in a couple of months. And then sometimes they get recurrent symptoms after 2 or 3 years. They're going back to crazy sports, and they can sometimes have more recurrent symptoms. We have to tell them, how to do therapy and stretch and get back to bed. So complications. This is why we don't do them every day, right? So pneumothorax, we've had a couple. Of the 160 patients, this was in our paper. We had I think 70 patients have surgery, but now we're for overall we're probably at 4 pneumothorax patients, 1 pneumonia. Pleural tear is, I would say, 50%. We don't document it very well because we don't do much with it. We've had 3 vein injuries where we've had substantial bleeding. We can put our finger on it, hold pressure, isolate it. We have specialized clamps that we use, Satinsky clamps, to help, sew it up. We recently had a subclavian artery injury. A patient had trauma to the area, had a clavicle malunion, first and second rib malunions. And so it was intimal injury to the subclavian artery that we didn't know about, that when we dissected the scalene off just caused some massive bleeding. No one's needed a intraoperative blood transfusion, but certainly an issue that we worry about. But we were able to stop the bleeding pretty easily with our fingers and clamp things off if we need to. Thoracic duct injury can happen on the left side. We've had one patient with the lymphothorax. I'm not sure how they got that, or chylothorax, and then a few with repeat surgery. The first patient I ever did, I just did a scalenectomy And then he came back because his plexus was snapping through his between his collarbone and his rib when he's doing overhead stuff. You could feel it snapping and twanging. You've got an ultrasound to confirm it. So pretty much we do a first rib resection on everybody in pediatrics because I think that's the main problem. It's almost never just scalenectomy problem. In adults, the literature is equivocal about doing scalenectomy and rib resection or just scalenectomy. But in kids, I think the scalenectomy is much more necessary for our patients to return. And early on, we had a couple of patients go back to sports too quickly, so we really have to slow them down. These are all aggressive athletes who want to be back at the pool tomorrow if we do the surgery today. So we have to slow people down. Otherwise, you go back too quickly and it can cause symptoms. So in our experience, thoracic outlet syndrome is young athletes, predominantly females, with repetitive overhead sports. I think that's a bigger problem that we're seeing now and more than ever. If patients who need surgery, first rib or cervical rib resection, scalenectomy, supraclavicular approach, I think you can see everything much better supraclavicular approach. Transaxillary approach, you can't find the scarring around the nerves. That's the craziest thing we see. We have to do a huge brachial plexus neurolysis because of all the scarring around that area. All that overhead motion compression causes significant scarring, and that leads to a lot of scar tissue that you have to remove, and that helps the nerves feel better, I think. But doing surgery on nerves causes more scar tissue, so it's a little bit of a little bit of an issue with that. So this surgery has complications. It took me about 50 to feel pretty comfortable with it, and 100 to feel like I know what I'm doing. That's a lot, right? It takes a lot to really get to know what you're doing with this area. I think having been a brachial plexus surgeon, doing a lot of brachial plexus surgeries on babies, doing neurolysis around these big neuromas, helps out a lot with your understanding of the anatomy and how to do this. But this is not something you should be taking lightly and not something you should dabble in. We're a center that does a lot of it, and I think we've got good success now. But we have a good algorithm, we have a good team. So thank you very much for the time. I hope you enjoyed the talk, and I'm happy to answer some questions.
Thank you, Kevin. Obviously, it's a tremendous experience for what's considered to be a fairly rare problem. I'm a believer that this is not as rare as people think it is. I see a lot of young adults who have been neglected for a long period of time, that their thoracic outlet begins at a young age, and it's missed. So I think if you're on the fence about believing that this exists or not, you have over 160 patients. We don't have anywhere near that number. We certainly have quite a few that have gotten better from a first rib resection. And I agree with you, by the way. I think Scott agrees that we generally will do a rib resection because we don't want to come back. Because once you have to come back, that's a really hard thing.
Yeah.
So
I avoid coming back as much as I can. I've had to do it a few times. So
yeah, that's difficult. So the couple things. We take the rib out as one piece. Tell me about morselizing and convince me to do otherwise.
Yeah. So, I mean, what we do, I'm not sure how you take it out as one piece, but we take a little kerosene like a spine surgeon, right? And, just grab a little piece of the rib, lift up, nibble out, making sure we see everything. Early on, we caused 2 of our subclavian vein injuries by biting a piece of vein at the same time. So you have to have good retractors. You need at least 1 assistant, but 2 is probably better. So you can have a bunch of Army, Navies, or Langenbachs in there to really help, and then you can nibble just enough to get, the anterior part free and then the posterior part free. So you think of the rib, take out 90% of the rib, kind of just underneath the collarbone to all the way back to almost where it articulates with the spine. So we're nibbling out, a good third of it here and a good third of it back here just to open up the space. And then we can work around the plexus to take out the piece of rib. I'm not sure how you take it out as one piece. That I'm not sure. Maybe you're a better surgeon than I am. Well, that's probably true, but
I think you've
it's hard to
proven that
do,
not
right?
to be the case. Yeah.
To me, like the rib is attached to so many muscles. The anterior medial scalene are big connections and a big wide surface area, and the intercostal muscles, those are the hard ones. Like you have these big thick bands, not just muscle, but like tendinous bands, because it's acting like your ribs are basically like blinds, right? You lift up one, the other ones are going to follow to open up the chest. So you have to release all those bands to get the rib out, and that's a lot of work. We've caused pleural injuries from that as well.
Yeah, we've caused pleural injuries as well.
Yeah.
So we do a lot of scraping, scrapey. And I think the key is retraction, as you say. You want gentle, but you want consistent retraction. And you have to, we work in windows. And what I'll say is we've gone to working really, we go way postero inferior to the plexus to start almost at the beginning of the rib, right off the spine, right proximal to the tubercle. And you start there, and then you start just elevating the muscle off the rib. You'll see the long thoracic as passes by, and you can avoid that. But we always find that. And then, we just do a lot of elevating of the muscle before we remove any rib, so that we have basically a clean rib all around and inferiorly. A lot of elevators. And as you say, you have to be really careful, and you have to really know what you're doing. And it's taken us a while to sort of feel comfortable with it.
Yeah, Dan, the other thing we've done that I think has been helpful is we deflate the lung. So we operate with many spine surgeons. So for our anesthesiologists to deflate the lung is not a big deal. So typically in the adolescent, we'll deflate that lung. And then just like Dan said, 2 windows, one posterior middle scalene and one at the level of the anterior scalene. And then nibbled, I agree, the Carson is the best instrument in the world for this. And once you've nibbled both windows, then you slide under and you take out a rib. But I agree. I just have to echo what Kevin said. If you the parietal, don't fix it. Right. And you may want to put a little drain in there, but don't fix it, because the one that Dan and I tried to fix, we got a tension pneumothorax, which is really a bad thing. So I implore you, don't try and close that parietal pore. You may have an underlying visceral injury that you don't recognize.
Yeah. So like we use a red rubber catheter. When we used to do that, we would put the catheter in and then sew around it and suck some air out and then tie the knot down. But like if you deflate the lung, I think it's easier. We're always doing with the lungs moving up and down. And so it's like you put a stitch in and wait for a second for the lung to go away. And so I've actually asked my anesthesiologist to make the patient stop breathing for a bit so I can, do stuff like take a rib out. But we don't try and shine the rib like you do in the spine, because we've had a couple of ribs try and grow back, right? If you take out a rib subperiosteally and leave it, it's going to grow back in brand new rib. And so if you leave some periosteum there, some bone's going to reform. And so we work hard not to leave any periosteum, which is probably why we cause more issues with the parietal pleura. But we don't release all the muscles off, by shining the rib. We actually have to cut through the muscles with a bipolar very carefully. And so I think what we need is a lighted bipolar. I don't think anyone's invented that yet. So if you guys want to work with me, let's make a lighted bipolar. We can.
So Kevin, I want to emphasize Dave has a great question.
Yeah.
Dave, you want to because my question is very similar. Why don't you go first?
Just as the difficult, or it is a difficult operation, but anteriorly where you're under the clavicle, where you're trying to get around under the clavicle, you've taken down the scalene, you've got your artery and your plexus mobilized, and then the vein it's tucked underneath the clavicle, and it is hard to get to and hard to see. And I generally just keep going around until I've got as much of it as I can. But if in the case of your subclavian vein thrombosis, are you doing it? You're doing it all from supraclavicular.
We are.
How do you see that subclavian vein? Because it's pretty
anterior. Yeah, I think the area of compression with the thrombosis is really anterior between the scalene and the clavicle. So you can see that part the easiest, and it's not really compressed distally as much. It's somewhat compressed at the pec minor. I think, one thing I didn't talk about is we do a pec minor release on pretty much everybody nowadays, unless there's just a thrombosis. because we've had so many people come back for a pec minor release later, and it takes an extra 10 minutes in surgery, so we might as well just do it. It's super easy to make a small incision over the coracoid, release the pec minor, make sure the plexus is free. The pec minor isn't a problem unless you're overhead. Like, it's really decompressed when your arm is down, but when your arm is up, it's really tethered underneath there, and the pec minor release can help. But that's about all that we do. We can kind of trace it up, from distal to proximal retrograde if we need to, but we're just carefully dissecting everything out in the anterior incision to free up the vein.
Sorry. You're not, Shay, how far around are you getting the anterior part of the rib? Where do you stop with that?
As far as we can see. So
yeah.
So sometimes you get like a little tiny piece of rib that can kind of move around. You can feel the mobility of it attached to the sternum, but we don't disarticulate it because that's right underneath the clavicle and right where the vein is. So that's really impossible unless you disarticulate the clavicle.
Yeah. And you never come below the clavicle as well to get that?
No, we've never had to. I don't think it's compressed in that space as much. It's really more compressed anteriorly for the vein, and so it's friable. There's a lot of scar tissue around it, and so I don't want to dissect too much around it because you can cause a big hole really easily. So
in a really scary hard place to go.
So we've thought about doing a clavicle osteotomy in some patients where we've had trouble with the vein, but we can usually see it and sew it up pretty easily, and we just have to have good retractors to sort of stop the blood flow through the vein on both sides. The beauty of the collarbone being there is that it's in the way when you're looking for the vein, but it's also an easy way to compress the vein against something hard to stop the blood flow. So if you ever have trouble bleeding, you just compress the vein, put your fingers underneath the clavicle, hook the vein, compress it, and you can easily try and find where the hole is. And I work with a plastic surgeon. We did all these together for the first 75 to 80, but we just don't have time to work together anymore for all of them. But she did a lot of transplant stuff. So she uses a Satinsky clamp. It's like a clamp like this. So you clamp it like that, and you can clamp around the hole, or kind of loop like this. And on this side, you can see the hole, sew it up, and then release the clamp. And then there's a vascular transplant tray we can use that has different angled clamps we can use to try and clamp things that are problematic. But we have all that like on the table because we know that if it's a problem, we want to have it fast and not just have to wait to call for something. But it's pretty rare nowadays. We're doing, we've just done so many that we feel more comfortable. Like for me, if it's a straightforward case, I can do the whole thing in an hour and 15 minutes. Take out the rib, decompress everything, decompress the nerves, do the pec minor release, sew everything up, and we're done in an hour and 15 minutes. So it's just knowing where to go and knowing how to get everything. It becomes a lot more straightforward when you're comfortable with it. But it used to take me like 4 hours to do everything, but now, it just slowly but surely you get more comfortable with it. So,
Kevin, the other thing is, so we have not routinely released the pec minor, but I think going forward we will. So just like we learned something from the first talk, we learned something from this talk. It would probably take us 15 minutes. I agree.
Yeah.
And this one more comment, I don't actually think the transaxillary approach for most of us is safe. And it can lead to a catastrophe without proximal control real quick. So if you've not done this surgery, or if you're going to do the surgery, I think you have to go supraclavicular and take out the rib. I think transaxillary is a problem.
Yeah, I know we've taken care of a few patients that had transaxillary approaches, and I don't think you can get as much of the rib out because you're, in the supraclavicular approach, you're like this far from the rib from your incision. In the transaxillary approach, you're this far. And, even if you hyperabduct the arm, it's a long way down there, and you can't get the whole rib out, and you cannot decompress the brachial plexus that way. And that's a big problem in these patients is the amount of scar tissue around it. So I agree. I think that it's the wrong thing to do transaxillary. It's not something that should be done by vascular surgeons in kids because they're not comfortable with doing what needs to be done. So we've had to go back in and revise a few patients that were done other places that had extra, ribs sticking in, especially posteriorly. And then, transaxillary, obviously, there are people who just deflate the lung and rip out the whole, rib, ripping out a giant piece of the pleura as well. I think we can do a better dissection and carefully, release it. So,
Kevin, it's interesting. I visited a group in South Africa where Leffert was, and he did mainly adults, as you know.
Mm-hmm.
And they looked up all their signs for carpal tunnels, I guess signs and symptoms, right? Yeah. And the one that was most predictive of having thoracic outlet syndrome and having a good result from rib resection was actually direct pressure on the lower trunk causing pain.
Yeah.
More so than the rus and the ats and all that hyperabduction stuff. Do you use direct pressure as
Mhm.
a sign?
Yeah, so I'm always palpating and feel like, is it sore right here? Do a tenalis here, tenalis at the plexus? Look for distal compression. We've done probably 20 where we've done a simultaneous ulnar nerve decompression at the same time as the thoracic outlet. We actually can do it separately. We did one, a couple days ago where I was doing the elbow and my colleague was doing the thoracic outlet release at the same time. So you can do a submuscular ulnar transposition with no tourniquet in about 45 minutes to an hour while someone else is taking the rib out and combine everything. Then, a few patients had quadruple crush, done Guillen's canal and ulnar nerve at the elbow plus the pec minor. And so I'm starting to wonder if some of these patients have a hereditary liability to pressure palsies, genetic variant. So I've sent people to genetics a few times. They have multiple points of compression as well.
Kevin,
So
don't
that's
take
something
it
to think
wrong.
about.
And Dan and I operate together a lot, but there's no way we're not together in the neck. I think you need to have a couple experienced surgeons in the neck if you can do this operation. I don't want Dan doing the Guillen's canal while I'm in the neck by myself or vice versa.
Yeah, well, I know we've done so many of them, and we're really comfortable doing it, so I can help, my residents and fellows retract, but I don't let them do much with surgery. And I used to let them do more, but I think I'm just older and wiser. I don't do that. There was a question about, thoracic surgeons, something like that. I don't. We did call on one of our general surgery friends when we had subclavian bleeding, when the subclavian artery was bleeding. But as a rule, we don't have the thoracic surgeons around because most of the things that are there we can take care of. Pleural tear, we know what to do with. The chest tube we put in before, so you don't have to have somebody there. But it does help to have someone there if you need to. So
Yeah, I have a couple final comments, Kevin. I don't
yeah,
know if
sure.
you can hear me. I had to switch off my earbuds because I ran out of battery. But a couple things. One, something you mentioned about as far as you can, particularly anteriorly. Posterior, I don't care as much, but particularly anteriorly, because you don't want the edge of the rib right where the vein is.
Mm-hmm.
And so I spend a lot of time making sure that the rib is quite rounded where I take even sharp edges. But I also try to go well beyond where the vein is.
Yeah.
To resect it. So, because it will pop up when you resect it.
Mm-hmm.
What was that? What was my other? Oh, number two. When we do get a pleural tear, which is, I think you're right, it's probably a 50-50 proposition. We'll put a catheter in. I don't sew anything, but I'll put the catheter in. And remember, we deflated the lung. And then I'll close around that catheter. I'll close the skin around that catheter. And then we'll reinflate the lung. We'll apply suction. And then we basically suck all the air out of the pleural cavity. And then we pull that out. And that will get rid of your pneumothorax so that your ICU staff doesn't bother you very much. Yeah. And then
Why are they going to the ICU? We don't use ICU for our patients.
We do ICU.
Yeah, I guess, I mean,
we're at the shrine.
Yeah. So like we don't deflate the lungs. So when we have a pleural tear, we generally don't have problems. I think the only thing we see sometimes is when they do a Valsalva, sometimes they like make them take a breath in. So they suck all the water into the lung pleural area and then they try and squeeze it out when they do a Valsalva. But we have them hold pressure at 30 millimeters of mercury for about 10 seconds to make sure there's no air bubbles coming out. Because otherwise you worry about, missing a pneumothorax. But it's pretty obvious when you have one because it's bubbling up constantly like a bubble. Two, I agree with you anteriorly. You really have to go as far as you can and really make it smooth edges. I've had to, in a couple occasions, like I said, have the anesthesiologist stop the breathing for a bit just so the lung doesn't sit there and like pop up and down over your sharp ridge edges while you're making it smooth. Posteriorly, I think you have to be aggressive because you don't know, when their arm is up overhead, how much posterior the clavicle goes. So I've had a few patients where it looks like we're doing enough, and then we move the arm up, and then it's pinching in the back. So I take more of the posterior rib out. The only thing posterior that I worry about is that the intercostal artery loves to hang out there and bleed. And so like I almost always cause an intercostal artery injury and have some mild bleeding, which you can control fairly easily with the bipolar. But that's the only thing about posteriorly. That's if I had to do a revision for someone else, it's almost always because there's too much posterior left. And I really am aggressive that way. I think we have a patient that my colleague did one side and left a little bit too much posterior rib, and I have to go back. But I don't want to go back. So you want to do this operation once, so you want to do it as much as you can in one sitting and never have to worry about it again. And so that's why we do, a huge rib resection and the pec minor at the same time, because it just gets it all done. But
That's great.
anyway, I've taken up too much of your time, so let's we can
All
go
right,
on
we'll
to
move on.
our talk.
Well, Francisco Soldado is not, his flight was delayed. So I will talk about something that Scott and I have been working on for the last few months, and we'll see how that goes. All right. Let me see if I can get my earbuds, if they're charged already.
All right. Can you hear me, guys?
Yep, you hear fine.
And you can see my screen?
Yep, for sure.
All right. All right. All is well with the world. Okay. So I'm going to talk about brachial plexus birth injury classification. And this is a study that was done with really the help of Clark Chen, who's one of our residents, who's one of the best researchers that I've ever worked with as a resident. For some reason it's not advancing. There we go. These are our disclosures. Abbreviations, we'll use AMS as active movement scale, Horner syndrome, and brachial plexus birth injury. So just by way of introduction, we all know this, but brachial plexus birth injuries result in about 1 in 1,000 permanent injuries per 1,000 births. And it can be a diagnostic challenge, particularly to find out which nerve roots are injured. And nerve roots lack protective tissue components like epineurial tissue or perineural tissue. And most of the resistance to axial strain comes from the perineurium in a peripheral nerve, and that's not really present in the nerve root. There are subtle variations in root innervation between patients that make a definitive diagnosis, preoperative diagnosis of what root is involved more difficult. And this leads to misinterpretation of the injury, even among experienced clinicians. I think all of us who treat brachial plexus birth injuries have been surprised that we've seen what we find intraoperatively compared to what we assumed we would find preoperatively. So just by way of historical context, we all use, or most of us use, the Neeraj classification, which was first published in 1987. And it was not published in a peer-reviewed journal, it was in a book. And so it's not necessarily been read by most of us who treat this injury. And I would really encourage you to read the original Neeraj description, because there's a tremendous amount of wisdom in there. And I think that the classification has changed over time as well, and not in good ways. So the original Neeraj classification, as intended by Neeraj, was a prognostic guide to be used at 2 to 3 weeks after delivery. So the way he described it is that 1 was primarily a 5-6 injury, and you would see shoulder and elbow flexion limitations. When you got to 7, that's when you started to see loss of wrist extension, loss of wrist flexion, and finger and thumb extension. By the time you get to the 3, according to Neeraj, was not a complete injury, because you still had partial or even complete T1 function. And then pupillary dilation, eye opening, basically a Horner syndrome. Neeraj said Horner syndrome is irrelevant to the injury. originally he considered having global injuries as 4 with Horner's or not Horner's, and then he decided to get rid of that classification because he found that there was no difference in prognosis between children that had a Horner syndrome and those who did not. Now, if you think about the way the classification has changed, one second. The way the classification has changed by Bissonella and Birch in 2003 and Al-Katan in 2009 and many others, we've sort of adapted the original intent of the Nerakis classification to the 3 and the 4 being essentially the same injury, but the only difference being the sympathetics, meaning a Horner syndrome. So we consider a 3 to be complete flaccid paralysis without Horner's, and a 4 to be complete flaccid paralysis with a Horner's. And that's sort of the common vernacular for brachial plexus birth injuries. But this is, again, not what Nerakis had intended his classification to be. He's expressly said that Horner's didn't matter. So this is the active movement scale, and this was our primary outcome measure. A total score is about 105, and you can see that it's a 7-point scale, 0 to 7, so I guess it's an 8-point scale. 0 being no contraction and 7 being full motion. And really the AMS score, for those who are not familiar with it, is a much more granular, nuanced way of judging muscle function than the MRC. And basically it fits in the space before, so if you think about an MRC being 0, no contraction, that would be a 0 in the AMS. And then a full motion number 7 would be a 3 on the MRC. So it's essentially, it takes 0, 2, and 3 and divides that into another 5 categories. So our objective was to review intraoperative findings and pre-postoperative AMS scores and to quantify the injury types on root level. We correlated the intraoperative findings with the AMS scores and the outcomes of the surgery. So we looked at retrospective chart review, and unfortunately, we don't have fantastic ways of looking back at our charts. We could find 164 patients with intact and sufficient records with a diagnosis of brachial plexus birth injury, and who had had primary brachial plexus reconstruction in approximately a 20-year period. 2 patients we excluded because of anatomic variations, and then we looked at all these other factors like demographics, et cetera. So average follow-up for us was 5 years, range up to 17 years. Average age at surgery was 5 months. Average age at initial consultation was 3 months. Site of injury was almost nearly split between right and left, which was kind of interesting. And Horner syndrome was present in 54 patients. So to get back to a little bit more of what Nerakis had intended, we created these injury severity types for us to be able to further define what we were looking at. And so an A was a C5-6 injury, and we tried to see if we could stratify that by individual roots, but it turns out that we had no C5 injuries that underwent, or C5 only injuries that underwent surgical reconstruction. So therefore, we felt that we did not need to have a subcategory separating C5 as its own injury. So then we had C5-6 injuries in A, 5-6-7 injuries as a B, 5-6-7-8 injuries, leaving a T1 hand as a C, and then a complete paralysis, as Nerakis described, as the final category. And then we went a little bit further in that we began to subdivide the categories by the number of nerve root avulsions, because we felt that nerve root avulsions were probably at play in worsening the prognosis depending on how many roots you had, because it really does affect not only your reconstruction, but your preoperative findings. So we looked at essentially the number following the letter is the number of nerve root avulsions. And you can only go up to a 2 because you only have 2 potential root avulsions in an A, whereas in a 5, you can go, in a D, you can go all the way to 5 because there are 5 potential root avulsions. And when we started putting them into this classification, we saw that the majority of patients were in this D category, and surprisingly, not that many patients in the C category, which means T1 sparing. But nonetheless, you can see that there's certainly a cluster of more severe injuries, which makes sense given that more severe injuries are the ones most likely to be fixed. We had 682 roots injured with 189 root avulsions and 27 partial root avulsions, as judged by our intraoperative findings. And our intraoperative findings are a combination of looking at the nerve and looking at stimulation of the nerve with the checkpoint stimulator. So our preoperative AMS scores, we averaged about 40, and then standard deviation was 20 because we saw a wide range of injuries. And we found a best fit trend line, which is a third degree polynomial, and that's the equation if you and we have an equation for that, and that's our R value there. So postoperative AMS scores 56 with a standard deviation of 20. So you see the numbers have gone up, and our correlation again with this with our best fit trend line was logarithmic with a fairly reasonable correlation, although not as good as our pre-op AMS scores. So this is, I think, the meat of the study. When we looked at our classification scheme subdividing based on avulsions, you can see that there's a fairly accurate and predictable decline in function and an AMS score as you go further from left to right, meaning more roots injured and more roots avulsed. And we were very happy to see that our classification actually has some correlation with the real world. And then when we looked at postoperative, which is the orange, you can see that we did not have a huge increase in our postoperative AMS scores compared to preoperative AMS scores. But that makes sense because we don't have as much to gain. When you look at the D5, you can see a huge improvement in the postoperative AMS scores. But there's also a huge variability. You can see this here. So when we looked at ANOVA comparison, there were significant differences between injury types and subtypes, and decrease in preoperative AMS with increasing severity and the number of avulsions. So there were specific differences that were notable. Preoperative AMS score for D was significantly different from injuries A, B, and C. And postoperative improvement was significantly different in B0 and C1 and all D subtypes. So when we compare Horner syndrome outcomes in all patients, it did make a difference. So if you were to look and say, do patients with a Horner syndrome, of all patients that are fixed, have a worse outcome than those that don't have a Horner syndrome? The answer is yes. But that if you go a little bit more into the data, if you take out the less severe injuries that never have or rarely have Horner syndrome, then what it tells you is that actually the Horner syndrome is an indicator of lower trunk injury, but it itself is not a predictor of outcome or a predictor of avulsions. It turns out that Horner syndrome did not correlate with lower trunk avulsions. And if you look at the anatomy, there are anatomic studies that show that in neonates, the sympathetic trunk is actually more closely aligned with C7 root than it is with the lower trunk. So again, nothing of statistical significance here. So the Neeraj classification, as it's understood today, underestimates injury complexity, primarily because Horner syndrome is really irrelevant. So our proposed classification redefines and refocuses on the original NARACS classification, but adds some granularity by independent consideration of C8 and T1 and inclusion of avulsions. We also included partial avulsions in our study, but that added too much noise to the data, so we decided to leave that out. So our key findings, AMS correlates well with intraoperative findings and with this new classification. It's a more accurate reflection of the injury severity and the outcomes. And the implications for clinical practice are obvious. It's improved predictive power for surgical outcomes. It allows us to understand the injury patterns better. And when we have a conversation, I had this injury and this was my outcome, or when we publish a paper, we can be a little bit more nuanced about comparing apples to apples if we have a more detailed classification schema. These are references, and thank you for your attention.
Yeah, thank you very much. Super. So I guess I have a question, maybe a query toward Kevin or David, some other center, is that if the presence or absence of a Horner's has no bearing on the findings, typically we'll use that as a finding to intervene early. Should we forget about that, Dan? Should we just go, okay, if there's a global injury and there's no recovery by 3 or 4 months, regardless of the presence or absence of a Horner's, we should operate? That's the question.
So the data says it's completely irrelevant. It doesn't predict avulsions. It doesn't predict outcome. It doesn't predict anything. It's not correlated with AMS. It's not correlated with anything. Yeah.
So Kevin, go ahead. Go ahead, David. Why don't you go first, David?
Yeah, go ahead.
So our practice, we don't see that many pan plexus injuries really, and when we do see one, if the limb, if there's lower trunk involvement, we are going to jump pretty early. But predominantly, we've got in Australia, we've got about a 35 to 40% cesarean rate. So we're seeing our injury profile is upper trunk A's and B's, not C's and D's. So we don't see them, but if we do see a total injury, we don't really pay much attention to Horner's. We just deal with the fact that if it's that bad that it's a total and it's there after 6 weeks or 2 months, where that's enough for us to start.
Yana? Yep.
That was a great study. And to answer your question, we haven't really cared about the Horner's syndrome either. So we have based our operations on the number of avulsions, or let's say if there is an avulsion on MRI, then we would usually suggest an operation. And obviously, if there is no recovery.
So Dan, back to you is an MRI helpful or not helpful?
I think an MRI is helpful, but it's not definitive. So I think an MRI is another data point in your assessment. So for example, let's say I'm looking at C8 and C8 looks normal, but it doesn't stim, and I have an MRI that shows that it's avulsed. I mean, I'm quite comfortable that that's avulsed, right? If I have an MRI so if I have the same scenario and I stim it and it stims just a little bit, then I'm a little bit confused, but I think maybe it's partially avulsed, right? And so there may be some rootlets hanging on. So I think it's very helpful. If I have a normal MRI and then I see something that doesn't stim all that well, and the root looks normal, oof. Yeah, I think it just becomes difficult decision making.
Yep. Melinda, help us out. You're raising your hand. Help us out on this dilemma.
So we have been doing MRI for many years, but with the most experienced radiologist and 3 Tesla MRIs, the fallacies in MRI report was almost 50%. and they take long time to get an MRIs to, and so the infants required anesthesia, and our decisions were not changing. Whatever the MRI report is, our judgments were based on clinical findings. So we have stopped doing MRIs before nerve surgery. So then I feel that anyways, we have to operate upon them, and our decisions will be based on what we see. Because many a times there are fallacies in MRI report, and so we have stopped doing an MRI and saved one anesthesia to the child.
So if you stop using the MRI, does the presence or absence of a Horner syndrome have any bearing on when you intervene?
Yeah, we follow the same thing. If there's a panplexopathy with Horners, we go in at 3 months, and there is no Horners, then we wait till 4 or 5 months. The thing is, we have every monthly HSC AMS. So if the child remains at the same level over 4 or 5 months, then we start, talking to the family that this child might need a nerve surgery. As Dan rightly said, that Horners may not have bearing, because we see Horners sometime when the child is flexing the fingers, and it is associated with C7 avulsion and not C8T1. At the same time, some Horners, they resolve spontaneously over a period of time. So, how to judge the Horners in the first month of life? Because sometimes it recovers, and sometimes it's not associated with lower root avulsion. So, we consider Horners, if it is persistent, then we take it as surgery. But MRI, it doesn't help us. We just go with.
So Dan's just telling us it doesn't make any difference. I guess the other question, and maybe I'll direct this to Kevin, is, there's always or sometimes an argument about what is required to have a Horner's. Like if you have a little ptosis or a little meiosis, is that enough, Kevi? Or what do you have to say it's a Horner's? And does it make any difference based upon Dan's data? Should we just ignore it?
I think we've ignored it for a long time because there's never a correlation. We've seen patients with like good finger function and Horner syndrome. Like that doesn't make sense. And you have patients with, 5 root avulsions and no Horners. You're like, that doesn't make sense either. So like, we don't really worry about, like, we just tell patients in families, like the Horners will get better. The other muscles will get stronger and it'll compensate. And you still might notice it when they're tired. You might notice a pupil change of color. That's about it. But other than that, we don't really think it's of consequence into the brachial plexus. I do want to highlight one thing that Dan talked about, that, the C8 injury T1 intact, like people forgot about that for a long time. People kind of lumped, Neurachus 3, Neurachus 4 together. And I think that's a very common injury pattern that we see, is that you have a bad injury, but you have a little bit of finger flexion, no wrist extension. They do this. That's a C8 injury, like C8 out, T1 intact. And we've seen that so many times that, it's something that we look for now. And no one really talked about it. So I'm glad you're bringing it back up to say like that type C or Neurachus 3 is really a 4 root injury, not a 5 root injury without Horners. And so, we see a ton of panplexus injuries. I think we rarely ever see the C5-6 injuries. Someone else is taking them. Maybe you guys are doing all the easy ones, and we're seeing all the shitty ones. Because man, I have never probably operated on a C5-6 injury. It's always been 5-6-7 or 8 or something. Like the 5-6 injuries either don't come to us or we just do nerve transfers later because they get enough recovery of other stuff. But like, the bad ones are showing up, and we're looking to see, like, do we have T1 function? If so, then great. We don't, the C8's avulsed, we can try and do something with that from C5 or C6. Oftentimes we'll see the motor, the motor rootlet and the dorsal root ganglion, and we can plug directly into a good motor rootlet with one strand of a nerve graft, rather than doing 4 strands into the whole C8 or 3 strands, depending how much time we have, how much graft we have, and how much space we have.
So Kevin, let me interject a second, because one thing that Dan and I were hoping that we would find from this paper is that what actually discriminates, a C8 and T1 hand from a T1 hand, like that, because a lot of times we've been surprised. C8's out, and everyone assumed preoperative by the AMS that there was if there were 7 on finger flexion, 7 on wrist flexion, do we need to look at intrinsic IP extension? Is there something on the physical examination we go, oh, that's a T1 hand, that's not a C8 T1 hand? You understand my question? Yeah.
Yeah, I think of wrist extension, finger extension. That's what I see. Like if they can do wrist flexion, finger flexion, that's probably T1. If there's any type of finger extension, even wrist extension, like you get C8 wrist extension a lot. So if you have a little bit of finger wrist extension, they probably have C8 intact. But like the dropped hand that's doing this, that's a T1 hand in our experience.
And Kevin, what about IP extension? What does that tell you?
I mean, it's hard to tell when your fingers are flexed, right? IP extension. It could be intrinsics, right? If you're doing this, if you really want to look for extension of fingers, you gotta have to do wrist extension, finger extension, right? Just like you're doing with the radial nerve palsy. Otherwise, you can get intrinsic finger extension like this, and people think that's finger extension, but that's really just intrinsic.
Yeah, I think so MCP joint extension is your clinical clue that C8 is intact.
Correct.
I got it. Okay. Thoughts on that? I mean, it's that's what we were hoping to find. Dan, I don't think we found that, did we?
But
No.
The problem with AMS scores is it doesn't discriminate between MCP extension. It just says finger extension.
Correct.
Best finger. I mean, you could do this, and that would be a 7 in finger extension with one finger. Like, what is that? I don't know.
So I think exactly what Kevin said. The AMS is not good for picking up the differences between MP extension, IP extension, thumb even. Everything is I feel like the hand is underrepresented in the AMS score. That's because it's generally lower down, right? So and therefore not as injured if you look at percentages, right? But I will say this: we were hoping to find a discrete barrier, right? Some sort of single thing that we could put hang our hat on. And we so far haven't found it. We're still crunching the data, and we're trying to use some AI stuff to see if we can figure out some pattern of AMS score that is predictive. But I'll say also what you're saying, I think we all know this sort of Erb's palsy, right? The way that people have described Erb's palsy, and Erb's palsy has become synonymous, even in the classification, even in the sort of modified Neuracus classification that has been handed down to us as Erb palsy as being a 5-6 injury. Erb's palsy is a 5-6-7 injury, and maybe even an 8. And exactly what you're saying. Because if you lose wrist extension, right, which is in an Erb's palsy, then you have for sure 7 involvement. And this is something that Gilbert talks about, that he's more than happy to do nerve transfers for what he calls a 5-6 injury, as long as there's wrist extension, right? Because you can't get that back, and that's a sign in my mind of a C7 and possibly a C8 injury as well.
I totally agree.
Mullen, go ahead.
Yeah, so I would like to ask that. Then I have observed in our patients that those patients who have good triceps, anti-gravity triceps, initially they have weak wrist dorsiflexion, but eventually they gain full wrist dorsiflexion. And if we look into this, we have a lot of neglected brachial plexus injury patients, or those who have come to us, we have advised surgery and they have declined. So we have huge number of those neglected cases, and there what I have seen is the strength of triceps is very important, and it defines the typical Erb's palsy and an extended Erb's palsy cohort. So how would you judge that, the triceps involvement? And if a child is having weak triceps, would you how is your surgical plan? We have some patients with some C5-6 movement, hand is functional but weak triceps, and then we worry that whether we should operate, we should reconstruct the plexus, or we should wait.
So I guess, Dan, the question is the presence or absence of the triceps affect your timing of surgery? I think that's I think Mo, you're talking about mainly an upper-ish injury, right?
Yeah.
So lower trunk where something's working, whether it's C8 T1, does the presence or absence of elbow extension affect when we pull the trigger?
Yes.
Dan, what do you think?
Yeah, I think triceps is really important. The problem with triceps is it's triply innervated, but primarily dually innervated. You can get normal triceps with an intact C8 as long as C8's not injured at all, right? And you'll have a normal triceps. We've seen that with C7 avulsions, where you had C6 injury, C7 avulsion, and then 8 was relatively unaffected, and you still had normal triceps function with full strength, as far as we could tell, right? It's hard on a baby, but that's how you can tell. And so I think when you do have weakness in your triceps, then that's a signal that not only is 7 likely out, but also 8 has been injured as well. And so that's now, right. And you may have, sometimes you'll get T1 will give you wrist extension and finger extension. It's rare, but it does happen. And so but it won't necessarily give you triceps. So I think in those cases, you're probably looking at R grade C, which is all the way down to C8 injury. And then if you have no triceps at all, I think that's very concerning for a complete C8. So now you're looking at maybe a C7, C8 avulsion injury.
I do have to say, though, I've seen a lot of patients that have T1 triceps. You know, if you do a four-root avulsion injury, you cut out everything, T1's intact, they're still doing this right after surgery. So you're like, I don't get it. Like, you know,
I don't think
triceps,
we've seen that full strength. I don't think we've seen that.
I can't say full strength, but I've seen AMS of 7 with C8 out, but it's, you know, AMS should not be confused with strength measurements because that's they're different, right? So it's function and strength are different.
And Kevin, I think Howard Clark's totally right. If you had one nerve root to have, you'd have T1.
Yeah.
Right. And Malaysi showed the same thing in that stabbing where the guy had full function. So T1 is definitely our most important nerve root. I think just trying to discriminate whether or not there's injury to C8. I mean, the worst thing is to be caught off guard, right? Mm-hmm. So, you know, you're in surgery and all of a sudden you're like, here's 5, here's 6, here's 7. Oh, shit. Here's 8. Now what? I got an avulsion at 8 and I didn't expect to have another nerve root, and then you're starting to figure out what to do with your viable axons. I think that's where it gets hard. And I think what Dan showed is great. I was just hoping to find the holy grail to say, you're exactly right. Lack of triceps, lack of something, that means C8's out. And we just have not been able to find that one factor that allows you prior to surgery to expect a C8 injury. Dan, agree?
Yeah, no, I think it's what Kevin said. There's too much variability in the root patterns. And if you think about the way the spinal cord is laid out, right, from our spinal cord injury experience, you have these rootlets coming out, and then they sort of group into roots, right? And sometimes those rootlets go up, and sometimes they go down to the next root. And so I think there's a tremendous individual variability, and that makes it very, very difficult to fully judge. I mean, you get a sense, but you don't know for certain. Yep.
Yeah, I totally agree. Like, you'd have to assume that every plexus is the same in order to find like a holy grail.
Exactly.
But I think, you know, we just have to like go by experience. And, you know, we've been there before where we had the C8 injury. We're like, now what? And we had to go talk to family and be like, hey, so we have to do a cross next C7 now. We didn't expect it. Unfortunately, that family was great and the kid has done awesome. But like, that's something you don't want to do in the middle of surgery. Like, just kidding, I'm going to borrow a nerve from the other side. And they're like, what are you talking about? Like,
and also the logistics of having to re-prep if you didn't anticipate. And that's one of the reasons we do get an MRI now. We really only get an MRI to decide to prep the other side of the neck. That's really it. Otherwise, there's really no point.
We just prep the other side of the neck if we're even considering it, and hopefully we don't do it. So it's much easier to do it that way than to, you know, change ship in the middle. So.
I mean, it's also, you know, we always take both surals in the beginning. Same idea. You just don't know what you're going to find. It's better to have too much nerve than not enough nerve, right? That's always a good thing. Yeah.
I think our planning is similar, right? We do prone, we do a spinal accessory suprascapular nerve transfer, we harvest both sural nerves, and then we flip the patient over. We give anesthesia to both legs so they can put IVs and blood pressure cuffs. Then we can prep out both arms, having to worry about it. It's a little bit of a fussy thing because they have to take an IV out of the arm that they struggled to put in the beginning. But it helps anesthesia feel more comfortable doing the case if we're, if we have to prep out both necks, we have both legs for them to use. So
yeah. And we do, Kevin, we do the same. We think it's from an anesthetic standpoint, it just makes their lives easier, because then they can put it in the arms and the legs. It's a better way to do it. Otherwise, you waste too much time by the time you get to the surgery.
Yeah.
Great.
All right.
Any more, Dave? Yeah, Dan, why don't you finish it up?
No, so I think appreciate everybody's time on this evening, afternoon, and morning. And I don't have anything else to say. Those are fantastic talks. I learned a lot.
Do we know what's next, Dan? Maybe that's the only thing that
I don't know what's next, but we do have a PULM session next month.
Okay.
I don't know who's leading it. And Andres, you wanted to say something?
Just to say thank you. There was great talk today, and I sent in the chat an invitation for a flap course that is going to be in November in Barcelona, 9 and 10 of Barcelona. I will read again. It's periosteal power course, and the email is so you can get it.
Yeah, I see it in the chat.
Power@gmail.com in the chat. Yes.
Yeah. Yep, I see it in the chat. I like the periosteal power guy. I like the emblem.
It's a little bit oof.
Oh no,
let's just say it doesn't necessarily look like a periosteum.
Oh boy. All right, everybody. Thanks for your time this morning, or it's afternoon or evening, whatever.
Yeah.
Cheers,
Thank you,
guys.
everyone.
Good night.
Thank you.
Thanks, everyone.
Have a good
Good to
day.
see you guys.
Bye-bye.
Yeah.